And we're live.
Good evening, friends. Today we are going to have a Dr. Sanjeev. Actually, Dr. Sanjeev Sabharwal doesn't need the
surgery conference.
It's a great pleasure to introduce Dr. Sanjeev Sabharwal. Actually, he's the one he introduced the Pediatric Orthopedic Society of North America to the India. He was the chief coordinator, and he is a chief coordinator between POSI and POSNA. He is the professor in the UCSF hospital. He's a director of the fellowship in the USCSF, and he does mainly on the deformity correction and the limb lengthening. He's one of the rare person who's got the training in both pediatric orthopedic and limb lengthening and limb deformity. He's having good research work and several papers on the limb deformity. And recently he has published the second edition of the pediatric lower limb deformity. It's excellent. First edition was there in 2016. Second edition is this August it is come, added with the new features with the comments after each chapters. And actually it is a word of wisdom from the many pediatric orthopedic consultants across the world. It is a great book, actually. All the fellow must read this book also. I'll not waste time. Over to you, Dr. Sanjeev. Please share this. Thank you very much for joining. Thanks.
My pleasure. Thank you, Hitesh, and thank you, Dhiren. I know Dhiren Bhai couldn't be here, but it's nice to see, Thomas and other familiar faces. So, and thanks to Posey. So let me share the screen and see if you can see my screen, guys.
Yeah. Yes.
Okay. Let me just make some adjustments here. Okay. All right. So, my task today is to talk about lower limb deformities in children, a case-based approach. And I was told by Hitesh and others that, this is really for advanced learners. So I assume most of you have finished your MS or post-graduation in orthopedics and are doing or have done pediatric orthopedic fellowship or advanced training. So I have a few cases. I think I have too many cases for the time that I have. So I may stop a little early just to allow time for questions, but let's just get started. So as Hitesh mentioned, these are really my conflicts also. I do have that limb deformity book. And as Hitesh mentioned, a lot of POSI members have contributed to it. So, and these are my other disclosures. So let's just get into the causes for lower limb deformity. And sometimes people have started challenging the word deformity as having a negative connotation for children and families and replaced it with the word difference, lower limb difference. But either way, we know what it means. So, when you see a child or an adolescent with a lower limb difference, first thing that comes to mind is it physiologic or pathologic? And I think we all know when children are born, they're bow-legged. By age 4, they're maximally knock-kneed. And by age 7 or so, they kind of normalize to what their adult lower limb alignment's going to be. So we're not going to talk about that. We'll talk about some of the pathologic etiologies, and I'll demonstrate with a case or two for each of these categories. And I've rearranged the categories just in terms of how, I have laid down some cases that we've addressed in the last few years. So I've intentionally tried to go with some of the more current cases, realizing that not all implants that you see here may be available to you, but I think it's still good to get the concepts and see because I think India, I know for sure, is like the capital of Jugaad. So, frugal innovations, creative technology is, where a lot of India can take pride in also amongst its, of course, many achievements. So I'm going to demonstrate some cases to you with some implants that, as I said, may not be available, but I think you guys can have creative solutions of your own. So let's get started. So in general, when you talk of treatment options in children with lower limb differences, there's really three options, right? You can observe it, see if it gets better or not. You can use guided growth in many different ways, or you could cut the bone and straighten it either acutely or gradually, right? It's just that simple. So you can also think of it as carpentry versus gardening. And I think a lot of people have sort of talked about it. But as a concept, carpentry is you cut the bone, you straighten it while the patient is still under anesthesia. And when they wake up, the bone is straight. So, has its pluses and its minuses. Or you could do it gradually. And gradually, you could do it either by cutting the bone and gradually lengthening or straightening it, or you could use the biology by tethering the growth plate on one side so that the bone straightens. I mean, these are simple concepts that I think you know. Um, and again, somewhat basic, but guided growth is biologic. It's based on the premise that compressive forces inhibit growth, and so you put a guided growth implant on the tension side of the deformity so that with time, if there's growth remaining on the compression side or the concavity of the deformity, the bone straightens out with time. Obviously, it's time sensitive. If you put extraperiosteal implants, it can be reversible to some degree, but then you've got to keep a close eye on the patient so they follow up appropriately so you prevent overcorrection. And it's really kind of awkward and embarrassing when the patient comes in a few years later and has the opposite deformity and are now skeletally mature. So you've created an iatrogenic problem. And can use it for managing both angular deformities and even leg length difference by doing contralateral epiphysiodesis, etc. And of course, what's attractive about this is also that it's a quick recovery. It's typically a short surgical procedure with a same-day discharge compared to osteotomies sometimes. Osteotomy, on the other hand, does allow for multiplanar correction. As I said, you could do it acutely or gradually, can lengthen, shorten. You often need some kind of surgical implants, but you can also address, three-dimensionally with, rotational correction. And of course, it's got a longer postoperative rehabilitation compared to, guided growth. There are variations in osteotomy techniques, in terms of where do you cut it, how do you cut it, do you use a saw, do you use multiple drill holes, osteotomes, jiggly saw, shape of the osteotomy, especially if you're doing acute correction, how is the correction obtained? Do you just cut it and fix it, or do you do fixator-assisted nailing or plating? And how do you maintain the correction, right? Intramedullary implants, extramedullary plates and screws, external fixator, etc. So while I'm not going to go into the details of pros and cons of these different options, I think through the upcoming cases, we can, get a flavor of, how we can do it. So ultimately, decision making is based on a lot of things, right? Patient factors and the surgeon and the environment that you're working in. Patient factors, of course, biologically, growth remaining. Is the growth plate that you're working on healthy, sick, or really not working? What is not just the current deformity, but anticipated deformity by skeletal maturity? I think that's important, and that's unique to the pediatric population. And then, of course, quantifying the magnitude, the plane of the deformity. What do the overlying soft tissues look like? Skin, is it tethered? Is there infection? And very importantly, the psychosocial issues, which is very different for each patient, each family, each community. And I think that in some ways are things that often get overlooked or not, because we all have cases where we just sort of look at an x-ray or a bone and say, I'm going to do this or that. And we don't pay enough attention to the patient, their psychosocial issues, support system, expectations, et cetera, et cetera. And then from a surgical and the environmental standpoint, what's available to you? What's your experience? What's your skill set? Do you have a backup? Do you have a mentor? Et cetera, et cetera. So developmental. So let's get into some cases. So these are a few cases I've chosen with Blount's disease, both early and late onset. So this is a patient who's probably 6, 7 years old, who had a couple of surgeries in the past, had an osteotomy with recurrence, had guided growth. But this is one where the medial aspect of the left proximal tibia, didn't respond to guided growth on the lateral side. And obviously it didn't because there was a bony bar. So, sometimes need advanced imagings like a CT scan to demonstrate that. So in this case, you could see on the CT scan that the lateral plateau is actually pretty level with the rest of the metaphysis, but the depression is in the medial plateau. And I think she was 8 or 9, if I'm not mistaken. So here we did just a plateau elevation, close the rest of the lateral proximal tibial physis and the proximal fibular physis, and put in a structural graft with fixation. Now, here's another case which is really humbling for me. A 7-year-old with early onset Blount's, right worse than left. And I think we did a guided growth on the left. And then on the right, we did an osteotomy with gradual correction. And, a few months into it, he was starting to correct the left side and the right side recurred. So here he is after missing a few appointments. And this is what I was talking about earlier in terms of, need for close follow-up. So it's not that it just happens in, countries where you don't have resources. Even in countries with a lot of resources, there are individuals and families that for one reason or another do not follow up. And you got to chase them, and still sometimes it doesn't work. So here he is, he missed a few appointments. So now he's got an overcorrected left side. It's gone from varus to valgus. The metaphyseal screw is broken on that left proximal tibia. And on the right, he's got, ongoing varus, which is much worse than where he started with. So we did, a plateau elevation, a medial plateau elevation on the right side, and got him better, but not perfect. And then we took out the broken implant or part of the broken implants from the left proximal tibia. And so see what happens over time. So the left went from varus to extreme valgus and now is drifting back towards the center. And then over time, the right gets corrected. I sort of break a rule in terms of knee joint obliquity versus limb alignment. And I do a guided growth on the right distal femur just to get his limb aligned. And you could argue that, well, you've created a little bit of knee joint obliquity on the right side. And that's true. On the left, he is not only, kind of maintained mechanical access, but he keeps drifting into varus over sequential x-rays. I tried to do a guided growth on the left proximal tibia, doesn't work. And by now he's more mature. So we do CT scans, and of course he's got a bony bar on the left proximal tibia too. So he ends up with a plateau elevation on the left. And then thankfully by skeletal maturity, he's got, decent limb alignment with near equal leg length difference. So I think the point of this case is that, in some ways it's not over till it's over. So you've got growth which can help you or hurt you. So you've got to keep that in mind. And if you're doing guided growth, close follow-up is important. And just because a deformity was somewhat reversible early on with a somewhat healthy growth plate, as the child matures, that growth plate can go from being sick to being dead. So you've got to keep that in mind. Okay, I don't do much adults, but this is a patient from many years ago who was actually sent by my total joint arthroplasty partner that he couldn't do a knee replacement because of the deformity. She's had many surgeries in the past in different parts of the world. I think she had early onset Blount's. And the reason to show this case is that what happens if you try correcting the varus, but not only does it recur, but you don't translate the distal fragment laterally. And I think, most of you realize that if the cora or the apex of the deformity is not where you do the osteotomy, then you've got to not just correct the angulation, but also appropriately translate the distal fragment. So, which was not done in this case. So here she is with an iatrogenic translational deformity, tricompartmental knee arthritis, but primarily it's the medial compartment. And you can see the numbers. She's also got some procurvatum, and they can't do a total knee replacement just because of the translational deformity. So all we did is, and that's kind of the rule or the corollary to Rule 2, Haley's rule in terms of what to do if there is the apex different from where the osteotomy is. So we just did a multiple drill hole osteotomy. This is from many years ago. And really, in order to uncover the deformity and correct the translation, you can see how much of that translation was needed laterally in order to do a biplanar correction and intentional slight overcorrection given her medial compartment arthritis. So people talk about this Fujisawa point, which is a sweet spot, 40% over on the lateral compartment. So, and surprisingly, at a 10-year follow-up, her knee pain was much better. She didn't want a knee replacement. And then, we'd done a left-sided correction as well. You can also combine techniques, right? So this is patient with late onset Blount's who's got deformity both in the femur and the tibia. She still has some growth remaining. The femoral deformity is not as bad, about 7-8 degrees, primarily in the tibia with some shortening and procurvatum. So you can do a guided growth on the femur and do gradual correction with lengthening on the tibia. So let's jump to metabolic causes. And I know you guys probably see a lot of rickets of all etiologies. So here is a patient with who's 16 years old, essentially skeletally mature, with a diagnosis of hypophosphatemic rickets, with varus on both legs, right worse than left, and the right leg shorter than left. And I think patients with metabolic diseases, especially from childhood, have, for the most part, multiplanar, multi-apical deformities, especially with hypophosphatemic rickets. So you don't want to just focus on the one most obvious deformity, but you got to do a thorough clinical evaluation and imaging to kind of look at it from all three planes. So if you did the analysis, and let's focus on the right side for now, she'd had few attempts at other institutions with guided growth and osteotomies in the past. And she's got on the right side in the femur, she's got varus sort of at the mid-distal third of the shaft. She's got apex anterior angulation kind of in the mid-shaft. In the tibia, she has procurvatum and varus and some internal tibial torsion, and she's short on the right side, right? So I don't think we have time to poll the audience, but I'll just show you what we did. And we can also talk about it during discussion. And then interestingly, don't forget the joints like above and below the knee. So at the ankle, she's actually got some varus and, can't see, but I think she's got some procurvatum as well. So the issue is, do you just tackle the femur? Do you just tackle the tibia? Do you do something at the distal tibia? Do you do it acutely, gradually, et cetera, et cetera? And I don't think there's just one correct answer. There's, many different solutions depending on, all these factors we talked about, both patient and surgeon. So issues to ponder, like we said, is do you do an opening or a closing wedge or a clamshell for the femur? Do you do a fixator-assisted nailing? Do you go antegrade, retrograde, 1 level, 2 level in the femur? And for the tibia, do you do it proximally, gradually with a hexapod fixator? Do you do a monolateral fixator? Do you need to address the distal tibial osteotomy? So a lot of variables. So I think like you all probably do, when you see deformity patients, it's always good to put down a problem list and revisit it. I feel like if you see a patient and then you just say, okay, I'm going to do surgery, and you don't think about it again, you sometimes will, miss certain things, and things come back to me. Like even now, I'll say something to the patient and family, but I'll almost always say, come back and let's rediscuss. And they'll have questions, and I would have thought about other solutions or options. So give yourself time. I mean, this is not an open fracture with a mangled extremity. You have time at your hand. So you've got to invest time, energy, and thinking to reanalyze. And I think that's the beauty and the challenge if you're going to do deformity as part of your work, is that you've got to invest time and energy and reflect on the cases and, learn from every case. I mean, I certainly learn from each case that I do now. So here we just took out the guided growth implants, did a fixator-assisted nailing, a 2-level osteotomy, antegrade nailing with some blocking screws. And then for the tibia, we did a gradual correction for length, alignment, etc. And here she is after the right side was done. And, sorry, can somebody mute, please? And then on the left, so the right looks good. The left is short. She's standing here in the center on a 1.5 centimeter lift. So she's a little short on the left. And what's deceiving in the left femur, it looks pretty straight, but if you look carefully, even on the AP, she's got a little bit of distal femur varus and midshaft valgus. And that's quite common in childhood deformities, right? Because things try to compensate. And then if you look at the lateral, she's got, pretty sizable procurvatum in the femur and a little bit of varus and procurvatum in the proximal tibia on the left side. So the issue is, do you buy it? And sometimes you're like, okay, it's not so bad. She's got large thigh girth, so she's not going to notice the varus. But then you also say she's young, she's healthy, her hypophosphatemic rickets is under control. She's a little short on the left. And that's where the sheer decision making comes into play. So we did and because of the distal deformity in the femur, instead of going antegrade like we did on the right side, we went retrograde, did another fixator-assisted nailing, and then for the tibia, we did a gradual correction and lengthening. So here she is soon after, the fixator came off, and now she's equal, her limbs are aligned, and she's actually very happy. So I think many ways. So that's not the only way to treat a patient with hypophosphatemic rickets with multiplanar, multi-apical deformities. In this patient, which was earlier in my career, we did a clamshell osteotomy because her proximal, it was a male, I think, his proximal and distal femur were fine, but he had this big sort of multi-apical deformity in the middle. So we could have easily done the same operation like we did in the last case, but here instead we did a fixator-assisted clamshell osteotomy. You lose a little bit more blood, but if people are just starting in this journey of, doing deformity correction with nails, I think in some ways this is a slightly easier operation, but more blood loss. But you have to choose your start point and distal target for the nail anatomically. So if you start at the right spot and you end at the right spot and take care of the middle by just kind of filleting open that middle segment with a clamshell kind of an osteotomy, and the Seattle group has, written a bit about this. They're the ones who popularized it. Then I think it's a great operation. So let's go to a case with infection. So this is a patient I saw, 7-year-old, who actually had not had any deformity correction, but she, as an infant, as a neonate, had septicemia, I think meningococcal septicemia, which again is pretty classic for attacking the growth plates. So she is 7 years when she presented, has left femoral varus, shortening of about 5.5 centimeters, no more infection. And you could sort of see an interesting phenomenon even on these numbers in the middle. So she's got an LDFA of 117, which obviously tells you she's in varus at the femur. But if you look at the tibia, she has an MPT of 97. So the tibia actually has tried to compensate a little bit for the deformity. And I think this is where, a thorough, comprehensive analysis is important, especially when you see children who've had ongoing deformities, because the body biologically tries to address deformities by compensating. It's not much different than why, let's say, a distal radius fracture in a kid remodels, right? Because the growth plate is very smart. So anyway, for this one, we did a left-sided. You have to complete, and I don't think I pointed out in the last picture, but on the MR and the X-rays, you could see she's got, asymmetric premature closure of the left distal femoral physis. And so the first thing you have to do is to prevent this from getting worse. And you could do it under the same anesthesia. So part of the plan was to complete the left distal femoral epiphysiodesis. Of course, it's going to make the short leg even shorter. You could address this with limb lengthening or contralateral epiphysiodesis or both. So here we completed the epiphysiodesis. We thought we completed the epiphysiodesis. We mounted a hexapod, and again, you could do any fixator you want. And then did gradual correction, and not just correction, but in anticipation of her, distal femur growth plate not working on the left side, we overcorrected and over-lengthened the left femur because she was maintaining her knee range of motion. And so you can see the left leg is actually longer now than the right side. And just like you do with some of the congenital lengthenings with external fixators, I think for the femur, it's a good idea when you take the fixator off after it's been on for many months to put an intramedullary device to protect the lengthening regenerate. I think more often than not, if I'm doing a pretty sizable lengthening, and I'm not using external fixators that much anymore for femurs, but I do still use them, that I'll often prophylactically nail them, at the time of fixator removal, and obviously address the pin sites. If there are any pin sites that are infected, we either take them out earlier or give a little pin holiday and then do the intramedullary fixation. But I think for the most part, if you ream the canal and you take enough precautions, you could do it at the same time. So we did that. We took the fixator off, did the prophylactic nailing, and so here she is. And the middle X-ray shows that she's standing on a 2-centimeter lift underneath the right leg, which is which used to be the longer leg. So now it is a little short, which was intentional. But over time, since the left distal femur is not growing, you could see that her leg lengths are, getting closer to equal. And then I noticed that she's developing a varus again. So we get a repeat MR, and despite my best intentions, and you saw the picture with the drill, I used curettes, you can sometimes miss part of the growth plate, especially in these, not so discrete bars that, patient like post-septic bar formation can have. So we went back, we put a guided growth plate on the distal femur, and then instead of doing something to improve her length and alignment right then, we waited till she was skeletally mature so that we minimize the number of surgeries. She's already had a few. So, and then when she was skeletally mature, you can see how now, 3-4 years later, she's got the anticipated limb shortening on the left. The guided growth plate, I think, did help a little bit to maintain alignment, but she was still in some varus. So because she's in varus, and if you're going to do an intramedullary, um, you know, lengthening with an implantable nail, as you lengthen, you're going to kick it into some valgus. The problem is that the deformity is distal. So if you did an antegrade nailing, I don't think you're going to address it that well. So you do have choices. You could make an argument of doing 5 different implant options, but this is what we did. And the principles of deformity correction stay the same, right? If you've got the deformity close to the physis or the physeal scar, and you're doing an osteotomy away from that, cora or the apex in the metaphysis, you've got to account for the translation that's necessary to realign the limb. So now I think some fluoroscopy machines, allow you to measure angles intraoperatively. So that's really, I think, another good little trick that we can sometimes use. So we did a retrograde nailing with a lengthening nail, put blocking screws over the concavity, which was, on the medial side, and then did retrograde lengthening. And then here she is at consolidation, and she's done quite well with maintaining motion. Now she's got equal leg lengths and essentially normal limb alignment. So I know I'm talking a lot, but let's just keep going. Hitesh, is that okay, right?
Yeah, okay, that's fine. It's absolutely fine.
Is the pace okay, or is it too slow, too fast?
No, it is okay, absolutely fine. I don't think so.
Okay, thank you. All right, so we'll show some post-traumatic cases, and I've divided these into 2, like the sequelae of physeal injuries and then some, extraphyseal injuries. So this was a patient who was treated by, by one of my partners earlier, very appropriately, a 10-year-old female with a Salter to distal femur, had a close reduction and percutaneous pinning or wire fixation. But as distal femur physeal fractures have a very high chance of causing growth arrest, post-traumatic. So she did develop apex anterior angulation. They tried to minimize it by putting implants anteriorly. It didn't work because the growth plate posteriorly had just shut down. So there was nothing to do. But you could argue that at least it prevented further deformity by putting these implants. And so she presented to me 3.5 years post-injury with a flexion deformity, right? It's not a flexion contracture. It's a flexion deformity related to an apex anterior angulation of the distal femur, right? And she's short. So again, I may have done it a little differently today, but this is from 5 years ago, and we did gradual correction with of her procurvardum, and my intent was to lengthen her whatever 5-6 centimeters that she needed through this osteotomy. And this is where I kind of misread the family. I thought they were gonna, she's been through so much, they're gonna, go with this whole treatment. But thankfully, I did the deformity correction earlier than doing the entire lengthening and deformity correction, gradually. So the bottom line was I lengthened a little bit, but dialed in the entire deformity correction. And as you can see, because the osteotomy was away from the apex, you do have to intentionally translate the distal fragment posteriorly in order to realign her axis. So I think the good news is we've realigned her, but she kind of decompensated. She's like, I want this thing off my leg. I don't want this on. I don't want to get more lengthening. So, so she's got now a straight leg, but still short. So, and then she disappeared for a few years. So she comes back when she's essentially skeletally mature and is about 4.5 centimeters short. The distal osteotomy is well healed. She's actually well aligned now, and the shortening is all in the femur. So now you can, switch gears, and you don't have a contralateral epiphysiodesis option. Even back then, she didn't want that. So you do an antegrade lengthening with a nail. And then, I think the one sort of advantage with the antegrade implantable or any implantable lengthening nail is that for the most part, you do maintain motion a little bit better than with external fixator. But there are definitely, downsides to implantable nails besides just cost. You can't protect joints, et cetera, et cetera. So these are some of the other ways you could have treated this patient, right? So I'm not going to go into all the details, but let's just read through these. So I could have acutely corrected the distal femur with, plate and screws and done a proximal intramedullary lengthening, either at the same time or staged. I could have done the acute distal femur correction and gradually lengthened via a retrograde IM nail because her growth plate was, nearly shut. I could have lengthened and corrected the deformity, which is what I tried to do here, but it didn't work the first time. I could have done an acute correction of the distal femur and plated it and done a femoral shortening, right? Could have taken like 4 or 5 centimeters from the contralateral femur. Not the preferred method for most patients and families, but if they don't want to go through the lengthening ordeal, I think that's definitely an option. I could have simply corrected the distal femur deformity and given her a shoe lift for the rest of her life or till she was ready for something else. So again, many options. Okay, another patient with a physeal injury, different. This one's in the distal fibula, so kind of uncommon. She's a 12-and-a-half-year-old ballet dancer who came in with left ankle pain. And the injury was 4 years ago. So you can see the right is the normal side, left you can see the fibula is high, and there is some evidence that she must have had some injury. So thankfully she came in with some x-rays from the time of injury. And really, she didn't have a very bad looking fracture, but she had a Salter 2 displaced distal fibular fracture, which was treated non-operatively. And you could argue that that's not an uncommon way to treat that fracture. So I'm showing this case just to show that you can dissect out the problem and then do it in a staged fashion to restore anatomy. But with deformities, especially long-standing ones, you've got to uncover all the deformities and then restore anatomy if you can, as long as there's not enough secondary changes, etc. So you could see on the top left, I've sort of put down as a stage 1 and a stage 2. So my first stage, she's got some distal tibial valgus. She's got a high riding fibula. I have an MR which shows that she's got, soft tissue, probably a flipped deltoid ligament in the medial gutter of the ankle. So my plan was insert a medial distal tibial guided growth screw because she's still got some growth remaining. Clean the medial gutter, debride the ossified, torn distal tib fib ligament, and then gradually bring the fibula down, because it's too much to acutely do it. Maybe some people will feel comfortable doing it. I just didn't think I had the skill set to acutely bring that fibula down by that much. So here we've got a fixator. The pins are in the proximal fragment in the tibia and the fibula, but there's nothing in the distal tibia. So we osteotomize the fibula, cut some pins to get appropriate length and diameter for the distal fibula, and then transport the fibula distally. And then when it got to station, then, hold it there with syndesmotic screw fixation, both rigid and with a tether, with the intention being that the rigid screws can be removed once the lengthening regenerate consolidates, whereas the syndesmotic sort of fiber wire, if you will, can stay as the new syndesmotic ligament. So here she is following implant removal, and she got her ankle mobility restored. She went back to ballet dancing, and so far she's doing well. Extraphyseal injuries, you could sort of, so this is a patient that I saw many years ago. And in some ways, these are lessons that you learn because yes, plating femurs, open plating is I guess an okay option, maybe not the preferred option most times. But you really don't need to put locking screws in that plate. And sometimes those locking screws can actually hurt you, especially if you don't put them exactly where they need to be. So he had these locking plate fixation done overseas and came back with broken, not sure if they were broken screws or they were just bending. The plate was bending and he had non-union 7 months post-injury. And of course, the femur's drifting into varus and his infection workup was negative. So I think that's another teaching point, that even if it doesn't look like an infection and it's post-traumatic, delayed union, non-union, always have a suspicion for subclinical infection. Do blood work, you can do biopsy, you can always stage it if need be. I mean, in this case, it was pretty clear that it was not related to an infection, it was a mechanical problem. So we did a one-stage, removal of implants, and then an intramedullary fixation, fixator-assisted correction of the varus, and just re-osteotomy. So in some ways, if you've got a delayed union, that that's where the apex of the deformity is. You could just easily kind of loosen it up a little bit with some osteotomes or drill holes, and take the implant out and reestablish the anatomic alignment. And of course, the reaming helps also in terms of bone healing. So again, one option to fix this. Here's another patient also from overseas who had a left femur fracture. The femur healed with a rush rod, but again, a rush rod or a non-locking intramedullary device is not going to control rotation. So her main issue was left-sided out-toeing. You could see it on the prone, exam, rotational profile, and also the way she walks. And look at her left foot and the left knee that's kind of turned out. So we got a CT torsional profile. You could argue that you don't even need this. You know it from clinical exam, and I think that's fine too. But if you have the resources and want to document the exact amount of malrotation compared to the other side, while CT scan is not perfect, I think it'll give you one more measure, so you can add that to the equation when you're sort of trying to derotate the femur. So here we just took the rush rod out, did a fixator assisted derotation, and then put in an intramedullary locking device. And then here she is, walking. So I think the point is sometimes you don't need a lot of fancy stuff, but of course, hindsight, if you're using a non-locking device, you got to think about controlling rotation, or use a locking device of some sort. Yeah. Okay. One more trauma case. A 13-year-old with a bad comminuted fracture that one of my partners took care of. Appropriately cleaned it, got plastic surgery involved, and then plated it. I think he needed a free flap. The free flap failed. And he ended up with an infected non-union with some bone loss. So I saw him then. So we took the implants all out, treated his infection, and got him infection free, put antibiotic laden cement there for a few weeks. And then when everything was clean, then, came back and then did just a conventional bone transport. Now you've got other options to transport, like cable transport, internal transport, etc. But this is just an example of a straightforward, conventional, proximal to distal unifocal bone transport, which I think in children still works quite well. Hitesh, you want me to keep going for another few minutes, or tell me?
Yeah, please go on. No problem. We have time. No problem. We'll have a question after that.
Okay. I tell you what, you can tell me when to stop. I just unmute and tell me, okay? Otherwise, I'll keep going. Okay. Well, this is an interesting one, and I put this out there because I know, you may see some patients still with adults with post-polio, etc. This was a sad case. She didn't have polio, but as a infant, she had a inguinal hernia repair, and it inadvertently, the general surgeon ligated or transected the femoral nerve in a 6-month-old, I think. And then it wasn't, the femoral nerve palsy was not diagnosed till many years later. Or many months later, I think. And then she underwent, cable grafting for the femoral nerve, et cetera, et cetera. But it didn't really work that well for obvious reasons that, it was a proximal injury. It was many months or years later, et cetera. So she presented at age 11 with a 4.5 centimeter leg length difference, a flexion deformity of the knee. And really, while she could walk independently, she had that hand thrust gait, as you see in post-polio patients, because of weak quadriceps. So, and she really came to me for another opinion. And, previous surgeons had planned antegrade femoral lengthening with the intramedullary device. So the problem is that you got to think about it long term, and right, you got to put in equation that she can barely walk independently with a hand thrust gait. Her quadriceps is not working well. She has a flexion deformity of the knee. You lengthen her femur, no matter which way you do it, you're going to create most likely more flexion, more tightness in the soft tissues. And while you get her length back, you may take a borderline ambulator, independent ambulator, to someone who cannot ambulate, independently. So I think this is where the challenge and the opportunity is for thinking ahead and saying, what are you going to do? She also has a little valgus in the femur, and you could see this is the left is her affected side, the right is the normal side. And over time, you can also look at the soft tissue envelope, right? I mean, look at the anterior soft tissue left versus right in the thigh. So you could see this, she really doesn't have much quadriceps to work with. So you need to do something to compensate for that. So, and I think most of you know, if you don't have working quadriceps, you can do an extension osteotomy of the femur to help with minimizing the work of the quadriceps so the patient can lock their knee in extension. So, these are the issues to ponder, right? You've got weak quadriceps, flexion deformity, valgus. The IM lengthening will make both the flexion and the valgus worse, especially if you do it intramedullary. So do you do a one-stage correction, two-stage correction? What do you do first? Do you correct her leg length or the deformity? What implant do you use? So these are some of the things that, you need to think of before you do something. So this was our plan, do a two-stage correction, do a fixator-assisted varus extension, closing wedge osteotomy, because she already has a scarred quadriceps with a tight fascia lata, right? You do an opening wedge correction just to save some length, you're going to make that knee even tighter. So you can always gain length proximally by doing a lengthening later. So that was my plan, to do, acute closing wedge osteotomy. And you could see on that bottom right, we kicked her into a little bit of valgus distally. I probably overcorrected her too much into varus. I could have done a little less, but it was okay. And so here she is after a few months, the osteotomy is healed. You could see now her mechanical axis on the sagittal view is much better. Like you can see she's sort of hyperextending her knee, and all she's left with is the shortening. And someone who's got weak quadriceps and has issues with knee leg lengths, you don't want to equalize the leg length. You actually intentionally want to leave that weak leg a tiny bit short, like about a centimeter or so. So with that in mind, we did a proximal lengthening intramedullary and intentionally left her a centimeter short. And of course, she's got some knee height asymmetry, but that's, I don't think, a big problem in this patient. And she's walking independently. She is actually really happy. She's not using any bracing. And, so at this point, she's okay. Maybe I'll just do one or two skeletal dysplasia cases and then we'll stop. This is a patient with metaphyseal chondrodysplasia with recurrent deformities. He's had multiple osteotomies done elsewhere with some recurrence. And if you look at it, these patients with metaphyseal chondrodysplasia sometimes behave like metabolic bone disease or rickets in children, right? They've got multi-apical deformities every place, hip, knee, ankle. So again, many ways to treat this. We'd written about this percutaneous. He's got coxa vara, and he still has some growth remaining, although he's short-statured. So what one option is to do acute correction of the coxa vara. You could see the slope in the proximal femoral physis, the Hilgenreiner's angle is pretty steep. So we did a percutaneous bilateral valgus osteotomies with a low profile external fixator with intentional lateral translation of the distal fragment. We've written about this a couple of times. And then for the tibias, we just did guided growths, both femurs and tibias on both sides. So here he is in follow-up a few months later. The femurs, proximal femurs have healed. And over time, in the middle picture, you can see the right leg actually looks pretty straight without osteotomies. The left leg is straight, but he's still got, and you could argue maybe this is okay and you should just stop here. And we had that conversation with the family. But he's got some varus in the distal femur. He's a little long on the left side. And he also has some internal tibial torsion, which you can't really appreciate because his left knee is pointing a little external. But when he walks, he sort of has an in-toeing gait on the left. So you could say don't do anything, or you could say do something to fix what's remaining in the tibia. And so we chose the latter. So, and again, you can customize it based on what the problem is and put everything in the equation. Of course, the family, the patient, natural history, growth remaining, leg length, surgical skills, acute versus gradual, implants available, et cetera, et cetera. So here he's long on the left. The problem is in the tibia, and the problem is varus, and internal tibial torsion. So a relatively simple option is a closing wedge osteotomy of the tibia. I mean, I do like fixators sometimes just for intraoperative control. And it makes it easier, especially if you don't have, a lot of help in the operating room, which can sometimes happen. And then intentionally overcorrected the varus a little bit. Not the prettiest construct, but I think it did the job. And I'm sorry, I don't have a follow-up picture. I thought I did, but he's doing well. Everything's healed. But he's still got growth remaining. This is the last case I'll show, and then I'll stop. And this again is to maybe demonstrate that you can mix and match, techniques that have been described for other problems. So I'll tell you what I mean. 11-year-old girl with left thigh pain and limp, who has polyostotic fibrous dysplasia, but primarily involving the left femur, right? And not only does she have disease in the proximal femur with the classic, shepherd's crook or varus apex anterior angulation, but on an MR and a CT, she's got some disease distally. So the question is, and she's short, right? She's short on the left side. So the question is, and you could see she's got extensive disease even in the pelvis. So she's still got some growth remaining. I think she was premenarchal at that time. And what do? You could use an intramedullary implant all the way through. I've had some bad experiences with doing acute correction in fibrous dysplasia when the bone is really soft, because you try to do everything anatomically, and sometimes the bone just cannot take that acute correction with a nail, even if you do it gradually with, I mean, not gradually, but with a fixator and carefully, etc. So here, the other thing which I thought was interesting is the approach. So you could look at this femur and say, this is like a congenitally short femur, and you could use a super hip approach to sort of address this. And that's kind of what we did here, is in terms of implants, etc. So, right, these are some of the issues we briefly mentioned. If you have the luxury of getting 3D prints, then I think that helps in cases like this. So here we sort of use the super hip approach, where and I think Paley's described it well in terms of where to sort of put in the implant, be it a blade for the blade plate or a lag screw for a DHS type of a device. So you put in your lag screw based on the angle of correction you want and the plate length that you have available. And then you cut the bone, closing wedge, and straighten it out. And in this case, because I wanted a slightly longer implant, I went with this plate that you see. The blade plates available to me were not long enough distally, and I think the blade length was also an issue. So here we used the standard, dynamic hip screw, long plate, and because of the distal, issues with the medullary canal having some, polyostotic fibrous dysplasia distally, and this becoming an issue at a later time, we protected the rest of the femur with a retrograde, simple, rod. And there are many variations to this, but we just use this one device which has threads that lock into the epiphyses so that the implant doesn't back off. But it's really just a simple nail. So she's straight now. She's asymptomatic. She's still got disease in her tibia, which is asymptomatic, but maybe will need to be addressed with something like a prophylactic nailing, etc. She's still short, so I don't have all the pictures here, but we did a contralateral epiphysiodesis, and I'm hoping that that's going to fix her leg length till maturity. If not, we'll do something later. Okay, last case. Just to sort of end on a sobering note, that you've seen all these patients and clinical examples of using fancy nails, plates, techniques. But sometimes you can go back to simple stuff. This patient was sent to me by one of my oncology partners many years ago, had had 2 or 3 operations for a recurrent aggressive aneurysmal bone cyst in the distal femur, and it just kept coming back. And I don't have the MR here, but the issue was that she had, or he had, a problem where the cyst was really very close to the distal femoral growth plate laterally, and he kept going into valgus. So we didn't do anything to the cyst. We just did a 20-minute operation and put a guided growth plate. And sometimes luck is on your side. This patient, straightened out. By the time he was skeletally mature, his legs were straight, his cyst actually healed partially. And the last I know, he's back to function. So I think this is another good lesson to say, like, complex problems don't always need complex solutions. You can have simple solutions for complex problems. And I'm just going to skip ahead now to kind of the last sort of summary slides, because the stuff I didn't cover is the congenital, but I think that's a big topic on its own. So, the final thoughts are, well, there's nothing new here, but I think it's worth repeating. For limb deformities, especially when you're treating kids and young adults or adults with pediatric problems, you got to focus on restoring anatomy function safely, keeping the family expectations, your skill set, your clinical experience, and what's available to you in terms of resources and implants, etc. Don't be too enamored with implants. They evolve over time. But you need to be rooted into sound deformity principles, because they don't change no matter where you practice across the globe, what you're doing, those things, the biology stays the same. And I think it's so simple and so obvious, but I think that's a lesson that's worth keeping in mind all the time. It's the same biology. So, look at the biology and understand the principles. And I think everybody's smart enough to figure out ways of fixing it. And I think finally, comprehensive plans, follow principles of deformity. You can always stage procedures. You don't always need to do everything under the same anesthetic, even though you have pressures from the patient, the family, your time availability, etc. And I understand that. But occasionally, if you set the stage and you say in the long term, it's going to be better to stage it, I think most people understand that. And follow patients to skeletal maturity, especially when you just do guided growth treatment. And, learn pitfalls. I mean, I didn't grow up knowing all the intramedullary nailing fixator assisted tricks, and I still have much to learn. But I think as you start doing more of this stuff, you learn from your partners, you learn from meetings, conferences, and every new technology comes with its own set of problems. So don't think that an implantable nail is going to fix every problem. It may fix some of your external fixator problems, but it'll certainly come with new problems. So I'll stop sharing. And and this is my website if somebody, an email if anybody needs to contact us later. Thank you. All right, Hitesh, I'll stop sharing.
Thank you very much for the word of wisdom. Actually, it is an excellent talk. I think we can cover the next time the congenital sometimes later, but we'll take a few questions. Thank you very much. Actually, the first question, the Meet asks that if we know about the sick physis, can we do the guided growth and osteotomy together or not?
Yes, you can. And I think it's interesting with the sick physis, you really don't even know, even with an MR or a CT. Sometimes it looks like it's not going to work and it still works. And the opposite is also true. it looks like it's patent, but it's not. And on the side, we've started using this thing called DTI, diffusion tensor imaging for MRI sequences, which is sort of like a functional MRI of the growth plate. And I think you don't need any fancy sort of MR machines. It's just that you need a radiologist who knows how to sort of read this. And there's this guy at Columbia University in New York, Diego Jaramillo, Jarmillo, who's written a fair amount about it, and we're working with him. But back to the question, yes, you can do a guided growth for a sick physis and correct acutely with an osteotomy. But then the question is, do you correct to anatomic alignment? Do you overcorrect? Do you undercorrect? And I don't think there's one straight answer. It depends on the situation, really. Sometimes, if it's not a very clean physeal arrest, meaning it's not just a spot weld and it's very irregular, like post-septic physeal arrest, I prefer to just complete the growth arrest and then deal with the osteotomy and lengthening later. But I think it's dealer's choice.
The comment was absolutely correct, because your case, Blount disease, the one case, the right side was more varus and left went into valgus. Then after waiting, it went into varus, and recurrence of varus was present. Actually, it was a sick physis.
Yeah,
And
exactly. Sick physis that eventually died,
yeah,
Then it went in, and that's
yeah,
like a Langenschuld stage,
yeah,
and I think he was right. Like
yeah,
early on, things are reversible, but when you get to stage 5, 6,
yeah.
they're
Very
irreversible.
irreversible.
Yeah, yeah.
Another question related to the Blounts: what is the minimum age at which you have done the hemiepiphyseal elevation?
Oh, elevation. Usually not before age 8 to 9. And the reason is that, and we've written about, the MRI morphology in Blounts. And, Truetta way back has commented, and you see it Hitesh, in your Perthes patients too, right?
Yeah.
Like if you have an insult to a growing chondroepiphysis, be it vascular, mechanical, or both, that you will have a cartilaginous onlog, like a chondroepiphysis. The structure's there, it's just not ossified. So when you look at a plain X-ray of early onset Blounts, it looks like the plateau is depressed. But if you do an arthrogram or an MR, you will see that maybe not totally level, but the chondroepiphysis unossified is there. And then there's a thickened medial meniscus that goes with it. So your joint level is not that off. But when the Blount's kid is 8, 9, he's sort of reached that stage 5, 6 of Langenschuld, then I think you're kind of done. And I think that's a good time to say, okay, does this patient have a varus thrust? What's the varus valgus instability? And of course, when you do that, you have to close the remaining physis laterally, including the proximal fibula. And then you've got to account for the limb shortening that's going to happen. And I actually think, and one other point is that sometimes you have deformity in the metaphysis and the epiphysis. Sometimes it's just one or the other. And you can cheat a little bit, but you can't cheat a lot. Like if you've got a truly depressed medial plateau, to do a metaphyseal osteotomy, I don't think is the right operation. Having said that, trying to overcorrect the medial plateau, which is very hard, and leaving a metaphyseal deformity is also probably not the right option, right? So sometimes you got to do 2 osteotomies same time or staged. Okay.
That would you do it 8 or 9 years, they will end up with shortening. So would you address at same sitting, or you'll do that stage wise most of the time? At stage, because
Yeah.
unilateral.
Yeah, no, I agree. And so that's why I said you have the option. If the family wants and they're fed up of external fixation, You could offer contralateral epiphysiodesis, right? You can also, like people have written, but I honestly have never done, not that there's anything wrong with it, people who write about it and do it, and it's totally doable. I don't do an intraepiphyseal elevation and a metaphyseal gradual lengthening at the same time, just because I want nice rigid fixation. I don't want things kind of going back and forth and then come back. I think I'm a big fan of stage procedures and do one thing, do it well, and then come back if you can. But you're right. You got, and that's the uniqueness with pediatric patients is you got to set the stage to say, even if the leg is straight and equal now, that's not going to stay that way. So you gain the patient's, and the family's confidence, and you plan appropriately.
That's another question for the Blounds. What is the minimum age for the hemiepiphysiodesis for the Blounds disease?
Yeah, that's a great
When should
question.
you do the growth modulation?
Yeah, that's a good. So that number has started going down a little bit. We certainly, I think that probably the youngest I've done is like a 2.5-year-old with very clear sort of blounds. I think before age 2 would be a little bit too early in my hands. I mean, people used to talk about, wait till age 4 and then do an osteotomy. I think that pendulum has swung a little bit. So I think to do a guided growth, in my mind, a 2.5, 3-year-old, when you're totally comfortable with the diagnosis, you don't want to do it for. I've seen patients come from elsewhere where honestly it was maybe a physiologic varus, and they've done, oh, it's Blount's, let's do this. And I think the other problem with guided growth in early onset Blount's is people see varus in the femur and they stick a plate on the distal femur. But you've got, and we've actually established normal joint orientation angles in children. It's a JPO article. So the LDFA doesn't have to be, it will not be 87 in a 2-year-old, right? So there is data out there. So just because you see a little varus in the femur in a child with Blount's doesn't mean you need to do a guided growth in the distal femur. And I'm talking early onset, not the late onset. Late onset, it's well known, a third of the time, third of the varus is coming from the femur or something like that.
Then one more question. What is your threshold for placing fixator spanning knee during femoral lengthening?
Yeah. You mean for congenitals?
Yeah, it must be for congenital short femur.
Yeah. I think so. They come in many forms. I think it's definitely you should protect the knee if you've got, ACL, PCL deficiency and you're doing a femoral lengthening. How you protect the knee, the ideal would be you reconstruct the ligaments and either do, either brace or you could use a hinge fixator like is being suggested. I've never done an unhinged, like just I mean, you can use hinge fixator and you could lock it in extension at nighttime. That's totally a very good thing to do. And I actually had some pictures of that. So I think that's great. If you just put a solid, unhinged fixator across the knee and you lengthen the femur, I have two concerns. One is that over time, as you're lengthening, it's really going to cause compressive forces abnormally, both at the distal femoral physis and at the knee joint. So I think if you don't allow the knee to move, that's a problem. Plus, when the fixator comes off, the knee is going to be stiff, not just from the lengthening, but just from being in the fixator for all these months or weeks. And then you try to chase it with osteopenic bone. And I've seen patients where, they do physical therapy, the femur breaks. So, if you're doing all that, at least protect the femur with an intramedullary nail once the fixator comes off and then do therapy. But I think the best thing is to, yes, protect the knee, but do it either with a hinge fixator or something removable, or just focus on maintaining knee extension with a splint.
Yeah. So one more question. In case of the rickets or hypophosphatemia rickets and the skeletal dysplasia, deformity is mainly at the sometimes at the diaphysis. What is the role of growth modulation? And when we are not like you have shown some couple of cases in hypophosphatemia rickets, it's applied pretty early, but it did not work. So experience also it is there. Few of the patients do behave very well, they correct very well, but some patients they do not behave very well with growth modulation.
Yeah, well, I think it also in hypophosphatemia ricket, it depends on the medical management too, right? Now you've got, so many, and I can't even name all the medications, but yeah, now they've got all these other stuff, which honestly is changes the natural history of limb deformities, I think. So you've got to keep, so definitely send them for medical management, endocrinologist or otherwise. And I think you're right. The deformity is typically more diaphyseal, but I don't think you could totally discount um, doing a guided growth in a patient with a diaphyseal deformity because ultimately, if you think about it, even if you have a diaphyseal deformity, let's say in a fracture situation, the bone remodels, and there are many ways the bone remodels. One is locally with, compression, tension side, asymmetric bone formation. But definitely there is literature and, we all have experienced it. There is asymmetric physeal growth. So I think as long as you keep in mind the joint orientation angles and you don't tilt the knee too far one way or the other, you can have a good mechanical access even if you've got a little zigzag deformity. I don't think that's a total no-no because what you gain in terms of minimizing the morbidity is there. So I'm sort of giving you a mixed answer that yes, growth modulation may not be ideal for diaphyseal deformities in kids, but I think it can still be used as long as you measure the angles and you don't stick a plate in the femur if the deformity is in the tibia. So you still have to follow those principles, right?
Yeah. And you are right. Actually, I heard the talk of the in Posna, the medical management with Burusmap. They claim that because of medical management, deformity gets corrected. With RS doesn't require even growth modulation also. Yeah,
Yeah.
Thomas is asking something. Thomas, can you ask, please?
No, I'm just amazed by Sanjeev's talk. Really nice talk, and so much I've learned. And the ballet dancer case was excellent. Really good, and the dysplasia case also. So I just the way he breaks down the thing. I think for the younger people, the fellows and the students, to know that Sanjeev has got so much of experience and probably I think among the lengthening experts I've heard, so clear in his concepts and his thing about writing down the problems, thinking about it, revisiting it is paramount, I think, for the younger people to understand and to understand that limb lengthening is not a one-off like you do a fracture. It's a lot of thought and it's a lot of revisiting, talking with the family, and we are constrained in India because of the costs and people not coming for follow-ups. But it's very important to actually think about what he said and digest it and break it down like he beautifully did. But Sanjeev, my question is
Thank you,
about.
Thomas. Thank you. That's very kind of you, but I know both you and Hitesh are masters at this.
No, but I'm just amazed that each time I hear you, I learn so much. And with your experience and your pediatric background, you've made it look complex things look so easy and doable. So my question is about you, Sanjeev. You evolved and you look like you're favoring lengthening over nail at the moment. So when you have so many arrows in your quiver, how do you choose which one to actually do for a complex deformity?
Yeah, no, that's a great question. And, I think it depends on the bone also, right? So in the tibia, while, let's talk about implantable lengthening nails. I still I try to stay like one fad behind. I'm not like an early adopter. Even for lengthening nails, I wasn't the first one to start. I kind of started a little late. It was almost embarrassing where people are like doing it. And I was like, yeah, I did one or two. So I think to me, that's a good lesson in itself, that you don't need to be the first to do everything. You let things settle down, understand, learn. Because when implantable nails came, people didn't realize that the tibia wasn't doing as well. People were creating iatrogenic deformities, compartment syndromes, the bone wasn't healing, etc. And then in hindsight, it made sense because your osteotomy is more diaphyseal, there's not much soft tissue envelope, et cetera, et cetera. So I think to answer your question, in general, if it's a uniplanar deformity in the femur, or it's just a length problem, short leg, straight leg, then I would do an intramedullary lengthening nail, and typically antegrade trochantery in patients under 18. If the deformity is distal, or if it's a really large thigh, and sometimes the magnet for a smaller nail can't even get to the bone, right? So you have to put it all in the mix. So then I think, so the perfect patient for a distal or a retrograde lengthening nail would be an obese patient with a distal metadiaphyseal deformity, right? And then when I say implantable nail, I think even now, doing lengthening over nail is a step in that same direction. And I think in some ways your learning curve will be much less. Like I think in PEDS, and I don't know what your experience is, like that wasn't something that I did for like 15, 20 years. I didn't do retrograde femoral nails. Like, the people were like, oh, stay away from the distal femur. But once you start doing a few of these, it's actually not that hard. It's really not that hard. You just have to know where the starting point is. And, it's okay. I mean, I hope I don't jinx myself, but it's not that hard, really not. But you have to sort of understand the anatomy and take it slow. For the tibia, I'm still old-fashioned. I will do fixators. I'm doing some fixator-assisted nailing, and then I think that's another thing you could do. Correct, because the implantable nails, the problem is they don't have the curve. They're straight nails, right? And you don't want to do an osteotomy and lengthening pretty close to the distal end or the narrower part of the nail. So there's so much to think about. And back to this concept of breaking it down into stages. You've got a complex deformity. You don't want to do a fixator. Even for the femur, you could potentially do a straight nailing, correct the deformity in all planes, close or open, and then come back and do a lengthening. And if you're doing a non-lengthening nail, let's say you don't have an available implantable nail, then it's actually better for you and the patient. You put in a locked nail, and you take the screws out distally and do an osteotomy around the nail, and then lengthen with a fixator over a nail. So I think there's so many ways to do it, but back to that whole thing, you got to stay safe, and you got to know how to bail yourself out. I think that's like the principle 101, right? For any procedure, peds or adult, or like, do operations that the pitfalls, and how to get yourself out of trouble, or you have somebody next to you who can help you, right? Don't take on these procedures, first time you just see or hear about them.
So about acute and gradual distraction in Blount's, I had a question, meaning how do you decide when to do acute correction in Blount's versus gradual correction?
So again, maybe I'm a little bit on one side. I almost never do acute correction in Blount's, in the sense that they have typically a multiplanar deformity, right? They have varus, they have procurvatum, they may or may not have internal tibial torsion, and a lot of times they're short. So I don't have the skill set to get it perfect. Having said that, I know people, including people in North America, who really take pride in doing a fixator-assisted nailing for Blount's and then lengthening. So I think it's doable. I think it's challenging, and I think in general, patients tolerate external fixators in the tibia much better, especially if you put it right and you counsel them appropriately, than obviously in the femur. And the one problem I have with acute correction in general is, as we know, it's a one-shot deal. You can't go back. And so I think it was Feldman did a paper a while ago comparing acute versus gradual correction, and it was a retrospective thing. But I think the point was acute correction is not as accurate sometimes, often. And you can get neuropraxias, you can get compartment syndromes, et cetera. So if you're doing an acute correction and you're not doing a closing wedge and it's the tibia, the least you got to do is do a prophylactic anterior compartment fasciotomy, watch the kid. Try minimizing circumferential casting early post-op. Don't send the patient home the same day. Don't do regional anesthesia or an epidural. So, all those things we talk about.
Yeah, thanks.
Excellent. Thank you very much. But last two questions, Akash and Siddharth would not be disappointed. Akash is asking, do you protect knee in non-congenital etiology for fixators?
Usually not. If they don't have any ligamentous laxity, you don't. But in general, when you're doing lengthening, you focus on maintaining knee extension because the flexion is easier to gain. If somebody is stuck with the knee flex 20, 30 degrees post lengthening, that's very hard to recover. I think, you could get knee flexion back, with other things, physical therapy, quadriceps plasty, et cetera, but getting knee extension back is much harder. So I think while you don't need fixator across the knee in general, I would splint them, not just splint them, but depending on the patient and the situation, I would discourage them to put a pillow underneath the knee when they're sleeping. I would, tell them to put something underneath their calf. And if the situation allows, then you can use a brace like a knee immobilizer at nighttime or something. Yeah.
Thank you. Last question, whether we do lengthening nail in PFFD?
Yeah, we've done. And I've done not just intramedullary, we've done extramedullary lengthening with nails. So I think that's another sort of creative thing again, others have popularized it too. So I have a couple of examples where for shorter femurs, especially, so you could use a short implantable nail, but instead of putting it in the canal, you put outside the canal, but under the muscle. So it's like a growing rod. And it's actually relatively simple, but then you have to put intramedullary, like a rush rod kind of a device to maintain alignment. And you still have to protect the knee. And I think that's the hardest part in congenitals, is that you don't have a fixator that you can hinge. So I usually use like a HKAFO with the knee in extension, hip in abduction, while the patient's getting, lengthening and lots of physical therapy.
Thank you very much. Actually, we have overshooted time. Actually, thank you very much for your precious time. On behalf of everybody.
Thank you, guys. See you in Ahmedabad in January.
Yeah,
Thank you.
thank you, Sanjeev. It was